Good morning, friends. On behalf of WIROC 2022, let me invite all of you all and welcome you all to this interesting symposium, the 101 of nerve injuries associated with fractures. Let me invite our panelists, or rather our faculty, Dr. Mansukhani, Dr. Mukund Thatte, Dr. Anil Bhatia, Dr. Parag on stage. So I'm not going to take too much time in this introduction, just to tell you all that this is going to be a presentation, 3 clinical cases by the faculty and Dr. Abhijeet. This is going to be followed by a talk on the basics of EMG NCV by Dr. Mansukhani. And we are going to have a question and answer session at the end of all of this. So without much ado, let me invite Dr. Parag for your first presentation.
Good morning, everyone. I thank organizing committee for this opportunity. I would like to discuss a case of 6 months post reduction of a shoulder dislocation case with no recovery in abduction and external rotation. So this patient is a 56-year-old gentleman and had a shoulder dislocation on 4th August 2020, and that was reduced on the same day. We don't have any details of his X-ray at the time of dislocation, and he presented to us in February 2021, 6 months after the dislocation, with pain, restricted abduction and external rotation of the shoulder. His biceps function was absolutely normal. In full supination, there was a good elbow flexion. His tricep function was also absolutely normal. So this is now the status at 6 months post dislocation. So triceps and biceps were functioning very well. The EMG nerve conduction, the first EMG study was done 4 months post dislocation, and it showed axillary nerve CMAP, they were not recordable, and there were no potential recorded in deltoid, supra and infraspinatus. This was the EMG done 4 months post trauma. And then when he presented to us, we got the EMG done, that is 5 months post trauma, and there was no amplitude recorded even at 5 months in axillary nerve. However, suprascapular nerve started recovering, and this was the report where it showed axillary mononeuropathy and only involvement of axillary nerve. So these were the CMAP, compound motor action potential, and comparison on the both sides. The radial nerve was functioning well, and the amplitude on axillary nerve on the left side was significantly low, and suprascapular nerve was functioning. The MRI finding, we got his MRI finding also, which showed a massive rotator cuff tear and a normal brachial plexus. So now I would like to have a discussion with respected panelists and faculty about, now we are dealing with the 6 months post dislocation, where the diagnostic dilemma is a complete rotator cuff tear and an axillary nerve injury.
I'm asking you. You're asking us to talk. Yeah. It is for us.
Should I present, or I would like to? So we will take questions at the end. So the treatment options like the discussion was, in stage 1, we should repair only rotator cuff first, and then consider some nerve surgery to gain the function in the axillary nerve as well, or both to be considered in one stage, or we should do only rotator cuff repair and should not do anything for stage 2. So these were the options that we had.
I think this would be a good time to open the discussion.
Yes, sir.
So he's put out his thoughts.
Can I say something?
Yes, sir.
Hello, please go ahead.
Yep. So, Parag, let's go rewind to your first slide. What is the mode of injury?
So the mode of injury was fall from stairs.
Sorry?
Fall from stairs.
It was a low velocity fall while he was walking downstairs.
Yes, sir.
Right?
Yes, sir.
There was no fracture noted primarily.
Yes, sir.
Right?
Yeah.
Did you examine the patient lying down?
Lying down? Yeah.
Yes.
I didn't examine the patient in lying down.
Let me put it to you this way.
Yes, sir.
Loss of abduction and external rotation is a loss of function of the rotator cuff and of the deltoid. Right? The supraspinatus is a muscle which is only 2 finger breadths in width. In a 56-year-old, slightly overweight individual, to expect the supraspinatus to abduct while standing is not a logical way to go about it. And therefore, you must demonstrate your examination of the shoulder while the patient is lying supine. The other thing that does is that it stabilizes the scapula against the bed. The patient's weight stabilizes the scapula. Therefore, scapulothoracic motion is eliminated.
Agree, sir.
So then you would have been able accurately been able to opine on the function of the rotator cuff at all.
Anil, good point.
Agree, sir.
When we take the discussion ahead, because we have very limited time.
Yes.
But yes, Mukund.
So, an identical case was treated by me along with Dr. Narvekar and was in fact put up in WIROC 5 years ago.
We've forgotten Mukund, remind us.
So, yeah, of course. So, this guy was just 1 month post-injury. Very, very similar findings. And we were discussing whether he should repair the rotator cuff or I should repair the nerve. And then they had a discussion in WIROC, and the advice he got in WIROC was do the rotator cuff first, because apparently the tendons turn to mush if you leave them for too long. Nerve can wait 3-4 weeks more. So that's what was done at that time. Now this is 6 months old. So I would do both in one stage. I wouldn't.
Anil, any thoughts on that?
I agree that if it is a combined suprascapular plus axillary injury, suprascapular tends to recover spontaneously. Therefore, rotator cuff repair would be worthwhile. Without that, you don't get any shoulder abduction. About the axillary nerve, in a low velocity fall, I would explore the axillary nerve in the deltopectoral region. It is very rare that the axillary nerve should rupture after just a fall downstairs. Yeah. So I would first confirm the need for nerve reconstruction and then plan on a nerve transfer. I'm quite agreeable to doing a nerve transfer at the age of 56, but I wouldn't waste time doing nerve grafting. But then I would confirm the need for exploration, for reconstruction by visualizing the lesion by the deltopectoral approach.
So you would explore the nerve at the same time that you're doing the rotator cuff repair?
I'm fully in agreement regarding primary management of everything in one go because it's already too late. But I would explore the deltopectoral region systematically.
Noted. Thank you so much. And we did rotator cuff repair in one sitting, and Dr. Dipit Sahu, shoulder surgeon, he could repair only one part of the rotator cuff, that too partially, because the retraction was too much. And I did a distal nerve transfer because of age and the duration of injury. And this is the result. Good amount of external rotation and around 120-degree abduction and forward flexion. So this is the result at 1 year. So to support references, I mean, the literature says that if it is at 6 months, how do we decide? Is amplitude of if axillary nerve is 30% or less as compared to the normal side, then it warrants for a nerve exploration and surgery. And of course, clinical findings are at most important before we make any judgment. Thank you.
Just a question to Dr. Mansukhani. Any comments on the EMGs done so far? Timing, should it have been done earlier? Any comments at all?
I think basically what was shown was that it was two nerves that were injured. One was the axillary and the other was the suprascapular nerve. Along with the amplitude, it's good to do a needle EMG of the muscle, because when you stimulate proximally, you're basically stimulating a large plexus. So you can get what is known as volume conduction from other muscles. So the CMAP alone is not reliable. You must see motor units with voluntary effort for you can conclude that this is recovery.
Thank you so much. I got it.
Okay, thanks Parag for that crisp presentation. Dr. Abhijeet is going to speak next on fracture of a radial nerve, fracture of the humerus with an associated radial nerve. Dr. Abhijeet.
Thank you. Good morning, everyone. Interestingly, this is a very common scenario that most of us would encounter sometime or the other in clinical practice. And through this case-based discussion scenario, let's try and understand how to deal with a radial nerve injury that may present with a closed humerus fracture. So this is a 36-year-old businessman who met with a motor vehicle accident about 3 months ago. And he was operated elsewhere for a closed fracture of the left humerus. And I'll show you the x-rays in the next slide. And unfortunately, he noticed an inability to extend the wrist, the elbow, and the thumb post-operatively. And the patient was apparently able to do that prior to the surgery. This is the fracture that you can see here, and it was treated in this manner. I think we will not belabor too much on the modality of fixation or the implant. However, here is a function of the patient for you to fall back on. You can see that there is some stiffness of the shoulder. He is not able to completely abduct his left shoulder. Even the forward flexion is quite restricted. Interestingly, even his external rotation was not all that great because of the stiffness. And let's focus more on the radial nerve function. And you can see that there is a very prominent wrist drop, and he can't extend his wrist. Finger flexion and wrist flexion was okay, and biceps function was also good. Triceps was also grade 4. That's his hand function for you to see vis-a-vis with the other hand. The right hand finger extension at the MP joint and the thumb extension and abduction were absolutely fine, whereas on the left side, the affected side, this function was grossly impaired. So at this point in time, I would like to beg the question as to what the diagnosis is. Obviously, this is a high radial nerve injury, and this is just a slide for all of us to appreciate what all is lost in a high radial nerve injury. At this point, I would like to ask Mansukhani madam, obviously we get electrophysiological tests. He's 3 months out. What would you suggest, and what are the usual findings that you would encounter? And this will be followed by a more detailed talk about EMG and CV by ma'am. Ma'am, could you please pitch in? Thank you.
Should I present with it, or you want me to answer that right away?
Yes. What would you expect, and what is it that we look for?
So basically what we are trying to determine electrophysiologically is going to follow in my lecture, but in short, we want to see whether there is any sensory motor continuity in the nerve, and if there is continuity, you want to determine whether there is re-innervation happening, especially at a time period of 3 months. You want to rule out additional nerve injuries, and that is what I'm going to elaborate in the talk which follows.
Right, thank you. Interestingly, this was reported by you, and this was the summary of the report, wherein she concluded that the prognosis for recovery is fairly good in view of sensory continuity being noted. My question to Dr. Anil Bhatia, sir, this has been operated. Usually there is some talk about using an ultrasound to look for any entrapment of the radial nerve. Would you like to comment on that, sir, please?
Thank you, Abhijeet. The first and foremost, any deficit appearing post-op, my first question would be, what approach was the patient operated upon?
So,
was it anterolateral approach or the posterior approach?
He was operated through a deltopectoral approach, sir.
Yeah, when I saw the X-ray, it is fairly evident. The anterolateral approach does not involve exploration of the radial nerve at all. So a deficit appearing post-op, one immediately jumps to the conclusion that the injury to the nerve was during surgery. So sonography would be a useful tool to locate the association of the nerve with respect to the implant. and the quality of the fascicles, because it's fairly subcutaneous and therefore can be traced all the way. If there is a suspicion that the nerve, in 3 months, it would show some reaction. And therefore, if there is a suspicion that the implant is one of the sources of the deficit, since the patient is pretty sure that the deficit appeared after surgery, for me, it is a direct indication for exploration.
Right.
Because if in future the nerve is going to recover spontaneously, good, we'll find out, we'll be able to confirm that during surgery itself. We would not do anything with the nerve. And if the nerve is actually injured by the implant, we would deal with it at an earlier stage rather than having waited 2 months and lost the patient's time.
Right, sir. Thank you very much. So there is some evidence about the role of ultrasound examination in such cases. So the problem is obviously loss of finger and thumb extension with wrist extension, which causes problems with the grip strength. And the treatment goals are listed here. I won't belabor too much on this. So in this particular case, whether we should operate or whether we should wait, especially if the ultrasound has not been done, and view of the electrophysiological reports. Thatte sir, would you like to please comment on this?
Sorry, what is the question?
The question is, now we have an electrophysiological report that says that there is a good potential for recovery. So in this particular case, taking the background in mind, would you like to wait or whether you want to explore?
So there are two parts. You mentioned ultrasound. So if you have done an ultrasound and if you see an injury, then there is no question of waiting. You must operate. But if on ultrasound the nerve is in continuity, you already waited 3 months. The fracture is at level of spiral groove roughly. Your brachioradialis should come back by 4 months, at the most 5. So I would wait till 5 months for brachioradialis. If not, I would explore, not wait longer than that.
Thank you very much.
Again, if ultrasound shows a lesion, then there is no question of waiting.
Right, sir. So usually the factors in decision making are the etiology of the palsy, the presence of concomitant nerve injuries and the time since injury, and of course the functional use of the extremity. So we are facing these options: early exploration, which has already been elaborated by Bhatia sir, exploration at around 6 to 8 weeks, and this may be usually associated with a nerve grafting, and then of course a late exploration with tendon transfers. I would like to ask the faculty, Parag, about what are the advantages and caveats for each of this, and Bhatia sir about the role of nerve transfers, which is kind of the new modality for addressing such problems, along with the so-called internal splint, which I would like to address to Thatte sir.
So in my opinion, the 3 months duration, nerve, after exploring the nerve, reconstruction by using a sural nerve graft is going to give a very good result. And so I would not consider any internal splint surgery at this moment, PT to ECRB.
Thank you. Bhatia sir, about nerve transfers, please.
There are two aspects. To me, age is a very important factor regarding nerve reconstruction. Beyond 35 is too late. So the patient is, I think,
36. 36.
Yeah. So he's crossed the borderline according to my criteria. So my options would be a nerve transfer or a tendon transfer. If I find that the nerve spontaneous recovery is not feasible after a proper surgical exploration. So if you look at the Bertelli's article, he says grade 3 function return at 1 year. So if I want grade 3 wrist dorsiflexion and incomplete finger extension and thumb extension at 1 year, and with tendon transfers, I can 100% assure grade 4 wrist dorsiflexion and finger extension and thumb extension at 1 month. I think the choice is pretty clear. I would go for tendon transfers. I am not yet on the bandwagon of nerve transfers.
Thank you, sir. Thatte sir, would you also recommend tendon transfers?
I don't like to do internal splint because I think it scars the area for a future tendon transfer.
Right.
I think the job of an internal splint can be done with a very lightweight Ubizoshi type of cock-up splint very, very easily.
Right, sir.
So I don't do internal splint. Between nerve transfer and tendon transfer, I do the nerve transfer. But I think Dr. Bhatia's point is very well taken. I agree with him, the power is different. Therefore, if you're happy to get good power and the patient is, I would do a tendon transfer.
Great,
Real
thank you.
point I want to add here, Abhijeet, what I personally do, if I know the surgeon or of the surgeon, I phone the surgeon and ask him or her whether you saw the nerve or not and whether the nerve was damaged or not. If it's a completely unknown surgeon from an unknown part of the country, then you have to assume the worst and think there is an injury.
I think that's a very, very pertinent and important point. Thank you for sharing that. So very quickly, in one sentence, take-home message for the audience. I'll start with Mukund Thatte, sir. In cases such as these, what would
So
you...
if you think the nerve is intact, if you have spoken with the surgeon and he or she assures you the nerve is intact, waiting up to 4 months for brachyradialis is worthwhile.
Right.
If you know nothing about it, and if your sonography and imaging shows you a affected nerve, then don't wait, operate it quickly.
Thank you.
That's the-
Bhatia, sir, a very quick take-home message.
If it is post-surgical, my inclination would be towards surgery, but I would do a sonography. The age of the patient would help me decide one way or the other.
Thank you.
The length of the defect in my practice has not been a major factor. Even defects greater than 7 centimeters, I have achieved nerve full distal function by nerve grafting in suitable patients.
Thank you. I think, ma'am, you will be elaborating in your talk, so I think we can skip that right here. Parag, would you like to please summate this up, please?
Yeah, in my opinion, duration and age of the patient and the defect size would matter the treatment choice intraoperatively. So counseling the patient pre-op till the end of the result is at most important. He may require a tendon transfer as a second operation.
Great. Thank you so much. I hope that was helpful for you all.
Can I make one comment?
Yes, sir, please.
Actually, about the question of splintage. One take-home message I would really plead, and I think Sudhir also would agree, please forget, delete radial dynamic cock-up splint from your brains. That is a default setting in all orthopedic surgeons' minds and should be eliminated. It leads to MP joint stiffness in extension and which is very difficult to control at long term.
I agree, the swan neck. Thanks, Abhijeet. While the next speaker comes, I agree that swan neck, huge splint with rubber bands pulling up the fingers, don't ever use that. And Anil, just you hold the mic a little closer when you speak.
This is a different presentation, sir. They have put my presentation.
Dr. Mansukhani is going to brief us on the basics, absolute basics of EMG, NCV, indications, timing, and so on and so forth. So over to Dr.
Good morning, and thank you very much for the organizers for including electrophysiology. I think somehow this has gone out of the screen, but basically I'll be using a radial nerve injury model to explain electrodiagnostic findings. So the outline of the talk, we deal with pathophysiology of the injury, what are the prognostic factors on electrodiagnosis, what is electrodiagnosis, who should be doing it, what are the indications, how does it help, when should you do the study, what should you look for in the report, when should it be reported, what are its limitations, how can the clinician help, and take home points. And that's a lot to cover in 9 minutes, and I'll try my best. So in Bombay Hospital, in the last 11 months, we've seen about 282 trauma, of which 49 were radial, of which 38 were radial alone, and of them 37 were with fracture humerus. And that's why I thought I'll use this as a model to explain electrodiagnosis. Pathophysiology of the nerve injury is very important to understand. You have two types of classification, the Sunderland and the Seddon, and without making it into grades, we talk about what is called neurapraxia, wherein only the myelin is affected, for which you require conservative treatment. Grade 2 is when the axon is lost, but the endoneural tubes are still intact, the nerve can grow back, again you need a conservative RA. The grade 3 is when the endoneurium is also damaged, and grade 4 when the perineurium, grade 5 when the nerve is not in continuity and you will need surgery. As we go along, we will see that between grade 3 and 4, electrodiagnosis cannot diagnose till the nerve reaches the target muscle, and that's a limitation. Now, how do we use electrodiagnosis for prognosis? Prognosis depends on the degree of injury, the extent, whether the entire nerve or few fascicles, how far is the muscle from the nerve injury. Certain nerves have very specific factors. For example, if you see, the radial nerve is one which recovers best from all other nerve traumas. The internal nerve architecture, the level of injury, whether it was one fascicle, multiple fascicles, then anatomical variations, and when you time the study is equally important. So what is electrodiagnosis? It's a series of tests for the function of the nerve. And when you say function, that means you clinically evaluate the patient and correlate your findings. It's not a standalone test. The sensory aids in localization. The motor aids in judging the severity, which is known as the CMAP or the compound muscle action potential. And the needle EMG is actually a judge of the power of the muscle. So who should be doing this test? A physician who's trained in this field. And when do you do it? When you suspect a nerve damage, however mild, and you have the time band interval to do it. And it is good to document a normal study when you are operating close to nervous tissue. How does it help? First of all, it objectively documents. It will help you to localize. It tells you the severity. It can sometimes aid in prognosis. It will detect additional nerve injuries which are mild. And of course, it judges clinical recovery. It judges recovery well before you clinically can document it. Now, these 4 points we will cover with 2 illustrative cases. Case 1, this is a 21-year-old male. He had a motorcycle accident on the 20th. He had polytrauma with a fracture mid-shaft humerus. They operated on 22nd, and the night of that, he noticed a complete wrist drop. So what do you think is the most likely type of injury? Is it neurapraxia? Is it axonotmesis? Or is it neurotomesis? You can just put up your hand. What do you think? Neurapraxia? All right. So one caveat is that the surgeon has noticed and visualized the radial nerve, found it to be intact before he closed up. Now remember, an injury that is so severe that it has fractured a bone will not cause neurapraxia. That will be your first take-home point. It's rare to get neurapraxia alone. You can get neurapraxia, but it's usually combined with some amount of axon loss. So how do we judge that? What will you do next? Will you do ultrasound? Will you reoperate? Will you do electrodiagnosis on the same day, or you will wait for the procedure a later date? Ultrasound. Remember, the nerve has been visualized, so you know it is in continuity. Yes, you will do electrodiagnosis later. How long later? 1 week, 1 month, 1 year? For diagnosis, for a radial nerve, 2 weeks are enough, but for recovery, 3 months. So let's look at the principle, timing of the electrodiagnostic study. Remember that when you have an injury along with a fracture, the site of lesion is somewhere in the mid-upper arm. Sometimes it is just a stretch at the point where the radial nerve enters the intramuscular septum. So you have a lesion which is affecting the brachioradialis and all muscles distal to it, and the radial cutaneous, and sometimes the posterior cutaneous nerve of the forearm. So this entire segment takes time to degenerate, which is called the clinical neurophysiological lag. That means it takes time for us to pick up. It's just a physiological limitation. It takes us time to pick up the axon loss, both sensory and motor. This is a limitation of the study. The snap drops completely by 11 days. The motor potential starts dropping on day 3 and can take as much as 9 days. Again, that depends on the length of the stump. So if you have a brachial plexus injury, it could take as much as 2 to 3 weeks. Same with the recovery. How soon you will see recovery depends on whether the lesion was complete or partial. If it's partial, the recovery happens by re-innovation. If it's complete, recovery happens by regeneration, which is an inch a month, so you can Imagine that it takes time for the nerve to reach your target muscle. Let's look at this report. This was the patient whom we started with. You can see the radial cutaneous has no response, but the posterior cutaneous, which is a nerve in the forearm, is showing some response. The important thing to note here is there is some continuity in the sensory fibers, which tells you the nerve is not in two separate parts. Then let's look at the motor study. You can see here, that there is no response from the EDC, but there is a small response from the ECRL, which tells you again that there is continuity in the motor fibers. And if you look at the needle EMG, which is the test to look for re-innervation, you can see these units, which are called re-innervating units, right up to the ECU muscle. So it's a radial neuropathy. It's severe but partial, and you can see re-innervation. This patient by November had recovered 95%. On the other hand, if you look at this patient, he is seen 6 months. We have no notes and he has no improvement. And as you can see here, there is no response in the sensory, no response in the motor, and there is no motor unit on EMG. So this is a complete axon degenerative. There is no function after 6 months. The limitation here is we cannot distinguish whether it's complete axonotmesis or neurotmesis. Still recovery is seen. Radial nerve electrodiagnostic features shows that even when the response is completely absent, 65% had full recovery. So how can the clinician help? I have two sides. Good to see surgical notes, intraoperative observation, and know your future plan so that we can do what we call a customized study. The take-home message is time the study, understand its limitations, share your information with the person who's doing the study. Thank you so much.
Are there any questions to Madam?
Just a comment. I think just like Thatte sir mentioned, it's very important to have a dialogue with the surgeon who operated. I think it's equally essential to have a dialogue with the radiologist and the electrophysiologist also. So talk to your electrophysician, your neurophysician as well as the radiologist. That's very important. Thank you.
Thank you.
Can I make a comment?
Go on.
We are looking at reappearance of motor units in the brachioradialis. For that, brachioradialis has to be contracted by the brain's order, and then only can you see the motor units. The brachioradialis is one of two muscles which require resistance by the examiner in order to activate any motor units. Therefore, the way of examination of the brachioradialis is extremely important to all clinicians. That is a resisted elbow flexion in the neutral position. It is only if the examination is done in that position, can you clearly say whether motor units are present or not.
I'm sure Sanjay Dhar is somewhere here. I think next year we should have a clinical examination to show us all of these. Sandeep, you have a comment?
Question to ma'am. In obstetric palsy in very young kids, how reliable is it to do an EMG nerve conduction because of the smallness of muscle needle placement? Because a lot of bad reports fly around and people make decisions on them.
Sorry, the question is?
In obstetric.
Can we do it? Yes, we can do it.
Obstetric palsies, how reliable is it to put your needles accurately in the...
It depends on the center where you send your patient.
Yeah, so it's very person specific, or it should be done, shouldn't be done?
Well,
it's open to all of you.
If the person is trained in doing electrodiagnostic evaluation, that's why I said who should do the study. If you send to a technician, yes, you're not going to get, reliable reports. Electrodiagnosis in children with obstetric palsies is a challenging, area of electrodiagnosis, and in our lab, only after 1 year of routine study is a fellow allowed to do electrodiagnosis in children. But I think Dr. Thatte can vouch for us that we do manage to do them fairly reliably. So it requires training. If that's your question, it requires training.
Sandeep, to answer your question, if I do all my studies with Dr. Mansukhani, and over last 25 years, I can tell you the reports are extremely reliable, both for prognosis and for diagnosis. But if a random person is done, and like she pointed out very politely, in many centers, technicians do the study, in which case the report is not reliable.
Yeah, the problem is everybody can't come to her from rest
But
of
her
Maharashtra.
students are all over Maharashtra now. We can share
Thank
those.
you, Sandeep.
Whether the OBPP
Sandeep, you
surgeons-
made your point. I think it's amply clear, not only in pediatrics, but also in adults. We get such absurd results sometimes that it doesn't lead us anywhere. And we've got to do a second test, and it's not a very pleasant test to do. Parag, your last presentation.
Hi, can I just ask a quick, Dr. Warrier, Parag here.
Yes, hi.
Hi, just a quick question to you and, Dr. Bhatia. When you said that, you never use the splints with the rubber band for radial nerve palsies. So probably all departments across in teaching hospitals, they are still putting it on. What do you recommend to be put?
It's called the gooseneck, not the swan neck. It's called the gooseneck splint, but it's a stupid splint because everyone leaves it on. It makes the hand very stiff. Just a reverse knuckle bender, or just as Mukund was saying, just a T-splint or a cock-up splint is good enough, because the IP joints are going to be extended by the intrinsics, which are innervated by the median and ulnar nerve. Parag.
Okay, the last case, I would like to present a case of ulnar nerve palsy in a united supracondylar fracture humerus in a 12-year-old child. So these were the x-rays 2 years back, a child with such kind of an injury at the elbow, and it was treated with K wiring, probably a percutaneous K wiring, and she presented to us 2 years, so 2 years post supracondylar fracture fixation with classical clawing of the hand, intrinsic weakness, and the elbow function was reasonably normal. This child had FCU function, flexor carpi ulnaris function was good, but it was lesser than flexor carpi radialis function. The important point here that I would like to mention in this child, that this child had some sensations preserved in the ring and little finger. To be specific, 2-point discrimination was 10 millimeter in little finger and 12 millimeter in ring finger, and crude touch sensation was present in this child in the ring and little finger. This was the report at 2 years of presentation, and the activity in adductor digiti minimi in the ulnar and introtia, there was no response at all. And even if you see, because the reason for sensations, they were preserved in digit 5, and in the report it was mentioned that there was no cross innervation from Martin Gruber anastomosis, like what if there is a frank injury to the ulnar nerve and still sensations are preserved, that is the second probable diagnosis we have in mind, but it was not there. Then we got the ultrasonography report done, and that showed a complete rupture of the ulnar nerve, and the distal end of the cut nerve was at 1 centimeter distal to medial epicondyle, and proximal stump was at mid-arm level. And they said that there is a gap of 12 centimeter. Here the dilemma that I would like to present to the respected faculty, that a young child, 12 years old, 2 years duration of nerve injury, has FCU action present but weaker, and sensations are preserved. So how should we, and elbow was absolutely asymptomatic, and there was no Tinel sign or signs of acute or the early stage of nerve injuries present.
Anil, thoughts on this?
Thanks for the question. This is 2 years post injury. Therefore, there is no question of attempting nerve reconstruction with a view to restoration of motor function. So, even nerve transfers are not a good idea. Therefore, I would plan for a tendon transfer and a claw correction. The young age might attract me to do a Bertelli type of distal nerve transfer for the first dorsal interosseous, for which we do not have a good tendon transfer option. But apart from that, this would go into the realm of palliative surgery and not nerve reconstructive surgery.
May I request Dr. Thatte sir to opine, please?
Yeah, so I agree with most of what Dr. Bhatia has said. So in the club Narakas meeting, for example, every year there is a session which says how late is too late. And nobody ever agrees on that. In children, there is always the temptation, like he said. So I would look for fibs. You should have a lot of fibs, 3+. Then there's certainly worth trying a distal nerve transfer. Now the question, you can't have a FCU and a ruptured nerve. There is some gadbad in this clinical finding. So the only reason to explore the main nerve, this child is very small. I am not sure I trust the sensory testing if there is no response. I might put 1 or 2 nerve grafts for future sensation because, you know, in a 70-year-old man I would not have, but in a 12-year-old child to leave her without sensation for 2 fingers, although you insist there is sensation, so that's very tricky. But I would do a distal transfer and I would warn the parents it won't work. And if it doesn't work, we have to do a tendon transfer. And if they are not agreeable, then straight away tendon transfer.
So, if if you would like to see, I can run the video to show FCU again. I had shown in that video. And second thing is the demand. Of course, it was not. The demand from the child was do whatever, but child should not lose the sensation what she has. And she was 11, 12-year-old. Even I counter checked it with my another hand surgery colleague that please check yourself. The child does have sensations. And should I proceed, sir?
Please go on.
Yeah. So the options here that we discussed is either we explore the nerve, consider the only factor is age, 11-year-old child, and consider a distal nerve transfer or a tendon transfer. I explained the parents that I would like to see how a close percutaneous K wiring can give a defect of 12 centimeter. So it was for my own interest. I told them that it is a one more incision, but I want to see the status of the nerve. And we explored the nerve, and this was the the findings were there was hardly 1 or 2 millimeter continuity, and there was complete fibrosis around from the medial epicondyle to mid arm level. And then I decided that no point in reconstruction this. And then we did a procedure called a distal nerve transfer. The red arrow is showing pronator quadratus muscle, and the nerve underneath the pronator quadratus is a anterior interosseous branch. And then we dissect the deep motor branch of ulnar nerve right from the Guyans canal, and we dissect it to the distal forearm. The absolute motor branch of the ulnar nerve, because here we do not want to disturb the sensory counterpart. And then the distal nerve transfer with the pronator quadratus branch to the deep motor branch was done after thorough counseling with the family that in future, after 1 year, if there is no improvement in intrinsics, I would like to consider a tendon transfer. So take home points is a clinical judgment and thorough investigation about exact status of the nerve from the clinical judgment as well as the electrophysiology and ultrasound. And duration of injury and age of the patient, definitely they are the important deciding factors, and we must discuss such cases with the seniors because they have definitely a diagnostic dilemma as well as a treatment dilemma. Thank you so much.
Anil,
I was not referring to this nerve transfer.
Okay.
The AIN to the deep branch of the ulnar nerve can at best produce the correction of the Wattenberg sign. What we are really concerned about is the pinch. And for the first dorsal interosseous, there is a different nerve transfer which has been published a few years ago, where we transfer a portion of the opponent's branch of the median nerve to the terminal branch of the deep motor branch. That is where it innervates the first web muscles in order to produce the thumb index pinch in this way. So that would be an attraction because we don't have a tendon transfer which is equally reliable, and doing a nerve transfer doesn't sacrifice anything. So AIN to the deep branch of ulnar nerve would at best give you abductor digiti minimi and the third volar intraosseous, which will just correct the clawing to a small extent. You would still need to do a Zancoli lasso later on.
Thank you so much, sir. Thank you so much.
I have one question, Dr. Parag and Dr. Anil, that how late will you do that? Because like this case, it was around 2 years post-injury. And considering that neuromuscular junction not functioning after 1.5 years or 2 years, although it's not giving any...
Can I take this question?
Yes, yes.
Sudhir. I have done distal nerve transfers in birth palsies even at 25 months with properly documented restoration of function. So, but then that is anecdotal. It could have worked the other way around in any case. So we should go in with the understanding that it can fail fully, and then what the surgery we could have done at the same time would have to be done 3 months later.
It's good to
May I answer that? You actually want to know whether the muscle is viable or not, right?
Right.
Before you do a nerve transfer. If you see, like Dr. Thatte said, a lot of spontaneous activity when you put in the needle, which is called fibrillation potentials, it tells you that this muscle is still viable. If you don't see that activity, you see no activity in the muscle, it means the muscle is fibrosed, and then you should definitely not do it. So I think you should use electrophysiology for that. Thank you.
Thank you so much.
I think thanks to the entire faculty, to the chairman, co-convener Dr. Abhijeet, and to all of you all for participating in this. It's been a good experience, and I think there are several take-home messages. So thanks again.